Hi there, my name is Nisha Tapawala. I'm a nurse practitioner student with Athabasca University, and today I'll be doing a verbal case presentation of a fictional patient for the purpose of demonstrating proficiency in presenting a clinical case. So my patient, Mr. M, he's a 31-year-old male with a history of smoking who presents today with a cough of 2 weeks duration. Mr. M is in a good state of health. He has a history of asthma, which was diagnosed at 8 years of age. The patient states asthma flare-ups are exercise-induced, and they occur about every 6 months to a year as he has a sedentary lifestyle. The last flare-up was about 6 months ago. He reports using his prescribed albuterol inhaler with good effect during an asthma attack. The patient also has a history of smoking about 10 cigarettes per day for the last 13 years. This is equivalent to about 7 pack years, and the patient has not attempted smoking cessation since he started smoking. The onset of cough was 2 weeks prior to clinic visit, along with a sore throat and a headache, as well as fatigue. Initially, the cough was non-productive, but progressed to a productive cough 5 days after onset, and it produced a yellow sputum. The patient also experienced worsening shortness of breath and fatigue 5 days after the onset of the cough. He states that both his shortness of breath and cough were exacerbated by inhalation of cold air and also by tobacco use. He frequently used his albuterol inhaler to treat the symptoms of shortness of breath, and though it was effective, he states that he did use his albuterol inhaler more than the prescribed interval. 4 days prior to clinic visit, the patient's sputum became yellow with a blood tinge, and he also experienced chest pain with severe coughing. He also experienced low-grade fever 3 times since then, and he treated each time with acetaminophen. The patient has a past medical history of asthma and smoking. He has a family history of heart disease, where his father was also a smoker and he passed away at the age of 55 of a myocardial infarction. His mother is currently a smoker and she is also diagnosed with hypertension, for which she takes antihypertensives, and it is well controlled. His grandparents on his mother's side have both passed away. His grandmother of breast cancer at the age of 78, and his grandfather of an ischemic stroke at the age of 78. And his grandfather on his father's side passed away of a myocardial infarction at the age of 67, while his grandmother on his father's side is still alive and she is 82 years old. She has a history of hypertension, type 2 diabetes mellitus, and she also uses tobacco and has COPD. He has no family history of lung cancer and no reported use of recreational drugs, and he has no reported use of supplemental oxygen. For his medications, he takes albuterol 90 micrograms per inhalation metered dose inhaler, and he takes 1 to 2 inhalations every 4 hours as needed during an asthma attack. He also takes acetaminophen 1,000 milligrams every 6 hours as needed, usually just for headaches and fever. Allergies include allergic rhinitis, for which he gets like a cough and watery eyes and sneezes when exposed to pollen and to dust. He also has food allergies to peanuts and shellfish, which cause hives and itching when he consumes them. He has a past medical history of asthma and tobacco use, and the patient states that he is up to date on all immunizations. He has been married for 5 years, and he has a 3-year-old daughter with his wife. He has a high school diploma, and he works as a customer service representative for Bell Canada. The patient reports drinking about 3 to 4 beers about 4 times a week. He states that he does not exercise regularly. On examination, the patient appears fatigued and short of breath. Vital signs are a temperature of 37.8, pulse of 100 beats per minute, blood pressure 134 on 80. He has an oxygen saturation of 92% on room air, and his respirations are 26 per minute. He does not appear to have any central or peripheral cyanosis, and there are no audible wheezes or crackles. The patient has an occasional productive cough with yellow blood-tinged sputum, and he complains of chest pain with coughing. Tactile fremitus is normal, and percussion reveals resonance throughout lung fields. On auscultation, there is wheezing noted to the upper lobes bilaterally, and there are coarse crackles noted throughout all lung fields. In summary, Mr. M is a 31-year-old male with a history of smoking who presents with a cough of 2 weeks duration. He has a history of smoking and exercise-induced asthma, and he presents today with a worsening cough, chest pain, shortness of breath, and low-grade fever. His lungs have crackles and wheezing upon auscultation, and his sputum appears yellow and blood-tinged. Thank you so much for listening to my presentation, and I look forward to your feedback.